Management of Monochorionic Twin Pregnancy, Green Top Guideline Number 51, November 2016. Purpose and Scope. It is recognized that women carrying a monochorionic pregnancy, most commonly twins, may have concerns and anxieties surrounding their pregnancy. This requires accurate information given in a sensitive manner by healthcare professionals and support by a multidisciplinary team, ideally within a multiple pregnancy clinic. Support is also often given in conjunction with the Twins and Multiple Births Association and the Multiple Births Foundation within the UK. Introduction and Background Epidemiology. A monochorionic pregnancy is a multiple pregnancy, most commonly a twin pregnancy, in which babies are dependent on a single shared placenta. Approximately 30% of twin pregnancies in the UK are monochorionic. Monochorionic placentation can also occur in rarer, higher-order multiples, especially triplets, for example, dichorionic or monochorionic triplets. There has been an increase in all types of multiple pregnancies with the increasing use of assisted reproductive technology, socio-demographic changes in our population associated with migration, and deferment of pregnancy to a later maternal age. Assisted reproductive technology increases the prevalence of both dichorionic and monochorionic twinning. However, using day 5 blastocyst transfers seems to have a significantly higher rate of monozygotic twinning compared with cleavage stage day 3 transfers. Monochorionic and dichorionic twin pregnancies have increased risks of preterm birth, fetal growth restriction or FGR, preeclampsia, postpartum hemorrhage, and postnatal complications such as infant feeding difficulties and adverse puerperal mood change. The particular challenges of monochorionic pregnancies arise from the shared placenta and vascular placental anastomosis that are almost universal and connect the fetal circulations of both twins. Specific complications associated with intertwin vascular anastomosis are twin-to-twin transfusion syndrome or TTTS, selective growth restriction or SGR, twin anemia polycythemia sequence or TAPS, twin reverse arterial perfusion or TRAP sequence, and single intrauterine death. Although not exclusive to monochorionic twin pregnancy, it is more common and has global effects on the co-twin. Monochorionic diamniotic or MCDA twin pregnancies carry a higher risk of overall fetal and perinatal loss compared with dichorionic pregnancies. Monochorionic monoamniotic or MCMA pregnancies, where both twins are in a single amniotic sac, 1% of monochorionic twins, carry a very high risk of perinatal loss, most commonly before 24 weeks. Almost all monochorionic placentas contain vascular anastomosis running between the two fetal umbilical cords within and on the surface of the placenta. These connect the fetal circulations. In 80% of cases, these are bidirectional vascular anastomosis, which rarely lead to hemodynamic imbalance between the fetal circulations, but allow a direct vascular connection between the twins with an increased risk of fetal death. In twin-to-twin transfusion syndrome, which complicates up to 15% of monochorionic pregnancies, the placentas have a predominance of unidirectional artery-vein anastomosis. This may lead to a hemodynamic imbalance within the circulations of the twins, directly adversely affecting fetal cardiac function, fetoplacental perfusion, but also adversely affecting fetal renal function by discordant activation of the renin-angiotensin axis. Very rarely, twin-to-twin transfusion syndrome complicates MCMA twin pregnancies, as well as both dichorionic and monochorionic triplet pregnancies. Twin anemia polycythemia sequence is an important association in complicated monochorionic pregnancies, especially twin-to-twin transfusion syndrome, occurring in up to 13% of cases post-laser ablation. Significant intrauterine fetal size discordance, difference in estimated fetal weight of greater than 20%, term selective growth restriction or SGR, occurs in up to 15% of monochorionic twins in the absence of twin-to-twin transfusion syndrome and in over 50% of monochorionic twins complicated by twin-to-twin transfusion syndrome. Selective growth restriction or SGR is recognized as a specific monochorionic twin pathological entity associated with a significant differing placental territory between each fetus, interfetal placental anastomosis, and abnormal fetoplacental blood flow. Complications associated with intertwin vascular anastomosis. Diagnosis of monochorionic twin pregnancy. How is monochorionicity diagnosed prenatally, and what is the accuracy of prenatal ultrasound chorionicity allocation? All women with a twin pregnancy should be offered an ultrasound examination between 11 plus 0 weeks and 13 plus 6 weeks of gestation, crown rump length 45 to 84 millimeters, to assess fetal viability, gestational age, and chorionicity, and to exclude major congenital malformations. Chorionicity should be determined at the time the twin pregnancy is detected by ultrasound based upon the number of placental masses, the appearance of the membrane attachment to the placenta, and the membrane thickness. This scan is best performed before 14 weeks of gestation. A photographic or thermal copy record should be taken and placed in the patient's notes, documenting the ultrasound appearance of the membrane attachment to the placenta and an electronic copy stored. If there is uncertainty about the diagnosis of chorionicity, a photographic record of the ultrasound appearance of the membrane attachment to the placenta should be retained and a second opinion should be sought. If there is still doubt in the diagnosis of chorionicity, the woman should be referred to a specialist without delay, as chorionicity is best determined before 14 weeks of gestation. On ultrasound, the fetuses in twin pregnancies should be assigned nomenclature, for example, upper and lower, or left and right, and this should be clearly documented in the woman's case notes to ensure consistency throughout pregnancy. First trimester ultrasound scanning is important in multiple pregnancies as it confirms viability, determines gestational age, defines chorionicity by denoting placental mass numbers and membrane thickness, determines the number of amniotic sacs, and may identify fetal anomalies such as large cystic hygroma and anencephaly. In monochorionic twins, it is also important to exclude a cardiac twinning, which is associated with TRAP, or twin reversed arterial perfusion. At this ultrasound examination, screening for Down syndrome may also be offered to couples. In spontaneously conceived twins, gestational age can be determined at the first trimester scan by using the crown rump length of the larger fetus to avoid the risk of estimating it from a baby with early growth pathology. There is significant benefit in identifying women with monochorionic pregnancies early, as these pregnancies will require additional fetal surveillance. It also allows women to be fully counseled on the risks and appropriate management of monochorionicity to be implemented. Differentiating between monochorionic and dichorionic pregnancies will result in a saving of time and emotional stress by avoiding unnecessary additional interventions and dichorionic pregnancies. Clinicians should be aware that, although ultrasound assessment of chorionicity is very accurate, it does not have 100% sensitivity. Approximately 3% of monochorionic placentas have two placental masses or bilobe placenta, so these are not necessarily dichorionic. Monochorionic twin pregnancies have a single placental mass and a thin intertwin membrane that inserts into the placenta at a perpendicular plane or T-sign. In contrast, dichorionic twin pregnancies have two placental masses or adjacent placental masses forming a lambda sign as placental tissue is present where the thick intertwin membrane inserts onto the placenta. This assessment should be followed up with noting concordant fetal sex at the mid-trimester ultrasound scan. It is sometimes necessary to review the assigned chorionicity of multiple pregnancies in the second or even third trimester. A retained photographic record, either in the patient's handheld notes or stored in the hospital notes, will allow this to be easily reviewed. An archived image should also be stored. If it is difficult to determine chorionicity, even after referral, for example, because the woman has booked late in pregnancy, then the pregnancy should be managed as monochorionic until proved otherwise. Accuracy in labeling monochorionic twins is important so that serial growth scan measurements can be consistently applied to the same twin throughout pregnancy, and that any intrauterine or neonatal management can be directed towards the correct twin. Outcome of monochorionic twin pregnancy. What is the outcome of monochorionic compared with dichorionic twin pregnancies? Clinicians and women should be aware that monochorionic twin pregnancies have higher fetal loss rates than dichorionic twin pregnancies, mainly due to second trimester loss, and overall may have a higher risk of associated neurodevelopmental morbidity. This should form a part of the parental counseling. Neurological morbidity may be up to 7-fold higher in preterm monochorionic infants compared with dichorionic infants due to associated complications of twin-to-twin transfusion syndrome, selective growth restriction, and single twin death in utero. Optimal screening for chromosomal abnormalities, structural abnormalities, and other fetal complications in monochorionic twin pregnancies. What is the optimal method of screening for chromosomal abnormalities in monochorionic twin pregnancies? Women with monochorionic twins who wish to have aneuploidy screening should be offered nuchal translucency measurements in conjunction with first trimester serum markers, combined screening tests at 11 plus 0 weeks to 13 plus 6 weeks of gestation, crown rump length 45 to 84 millimeters. In women with monochorionic twin pregnancies who miss or who have unsuccessful first trimester screening for aneuploidy, second trimester screening by the quadruple test should be offered. Early data with non-invasive prenatal testing or NIPT are encouraging, but results should be interpreted with caution until larger studies have been carried out. Monochorionic twins are not at increased risk of chromosomal abnormalities over dichorionic twins, but the prevalence of aneuploidy is slightly increased overall in multiple pregnancies because of an indirect association with increased maternal age. First trimester combined screening using nuchal translucency and the serum analytes of free beta-human chorionic gonadotropin and pregnancy-associated plasma protein A, combined test screening, should be offered to pregnant women with monochorionic twins at a crown rump length 45 to 84 millimeters. This screening test has good sensitivity for detecting aneuploidy, 90%, but the false positive rate up to 10%, is higher than in singletons, 2.5%, and dichorionic twins, 5%. When screening is performed by nuchal translucency, first trimester serum screening, and maternal age, a pregnancy-specific risk is calculated in monochorionic twins. This is in contrast to dichorionic twins, in whom a fetus-specific risk is calculated. Approximately 10% of pregnant women do not have their first antenatal booking appointment in the first trimester. If the gestation at first visit is after 14 weeks, then second trimester serum screening should be offered using the quadruple screen test with an 80% detection rate and a false positive rate of 3% so as to not disadvantage these women. This screening test in monochorionic twins provides a pregnancy-specific risk. Non-invasive prenatal testing or NIPT for fetal trisomy 21 risk assessment is now available and is rapidly replacing other screening tests. In a 2014 meta-analysis, the weighted pool detection rate for trisomy 21 in singleton pregnancies was 99% for a false positive rate of 0.8%. The corresponding values in twin pregnancies were 94.4% and 0%. NIPT in twins versus singletons demonstrated that failed test rates or failure to get a result were higher compared with singletons, 5.6% versus 1.7%. What is the optimal method of screening for structural abnormalities in monochorionic twin pregnancies? All monochorionic twins should undergo a routine detailed ultrasound scan between 18 and 20 plus 6 weeks of gestation, which includes extended views of the fetal heart anatomy as recommended in the Fetal Anomaly Screening Program, screening of a singleton fetus. Structural abnormalities, particularly cardiac abnormalities, are more common in twin and higher order pregnancies than in singleton pregnancies. This is mainly because of the higher incidence of abnormalities in monozygotic twins, owing to the unusual nature of the cleavage of the conceptus compared with dizygotic twins. Monozygotic twins are monochorionic in 70% of cases, hence the higher rates of abnormality in monochorionic twins. Abnormalities specific to monozygotic twins are often midline, such as holoprosencephaly, neural tube defects, and cardiac abnormalities. As one cannot determine monozygosity using ultrasound, both monochorionic and dichorionic twins have the same recommended second trimester ultrasound screening regimen, which is in line with the National Institute for Health and Care Excellence Guideline. The management of monochorionic pregnancies, where one fetus has a congenital abnormality, is complex because of shared circulations within the placenta. Timely diagnosis facilitates management by allowing time to prepare, optimization of fetal surveillance depending on the anomaly, involvement of multidisciplinary specialists, for example, genetics team, pediatric cardiologists, and pediatric surgeons, and appropriate birth planning, place, timing, and mode, including access to intrauterine management where it is possible. Selective termination of a single fetus in a monochorionic pregnancy should be assessed and carried out in a center with expertise and experience in performing such prenatal procedures. In addition, increased prenatal surveillance, the potential for referral to a tertiary specialist center, and the adverse risk to the pregnancy must be discussed in a timely fashion. What is the optimum ultrasound regimen for monochorionic twin pregnancies? Fetal ultrasound assessment should take place every 2 weeks in uncomplicated monochorionic pregnancies from 16 plus 0 weeks onwards until delivery. At every ultrasound examination, liquor volume in each of the amniotic sacs should be assessed and a deepest vertical packet or DVP depth measured and recorded, as well as the umbilical artery pulsatility index or UAPI. Fetal bladders should also be visualized. Although first presentation of twin-to-twin transfusion syndrome is rare after 26 plus 0 weeks of gestation, it can occur and therefore scans should be performed at 2 weekly intervals in uncomplicated monochorionic twins until delivery. From 16 plus 0 weeks of gestation, fetal biometry should be used to calculate an estimated fetal weight and the difference in estimated fetal weight calculated and documented. As the risk of selective growth restriction extends to delivery, this should be performed at 2 weekly intervals until delivery. There are a number of serious pathologies in monochorionic twin pregnancy that need to be screened for routinely. Ultrasound is required to make this diagnosis, and therefore, serial ultrasound is required at regular intervals. Ultrasound examinations between 16 and 26 weeks of gestation focus primarily on the detection of twin-to-twin transfusion syndrome. After 26 weeks, the main purpose is to detect selective growth restriction or concordant growth restriction, and more rarely, twin anemia polycythemia sequence or late-onset twin-to-twin transfusion syndrome. This ultrasound screening should include, as a minimum, fetal biometry measurements, head, abdominal, and femur measurements, measurement and recording of deepest vertical packet depth of both socks, and evaluation of fetal bladders, for example, size and visibility. From 16 to 0 weeks of gestation, estimated fetal weight should be calculated and documented. In addition, if at any point in time there is evidence of significant growth discordance or a suspicion of twin-to-twin transfusion syndrome, then umbilical artery pulsatility index or UAPI, middle cerebral artery peak systolic velocity or MCA-PSV, and pulsatility index and ductus venosus Dopplers should be performed. From 16 weeks of gestation, umbilical artery Doppler velocities should be evaluated and the presentation of positive, absent, or reverse velocities noted and documented. From 20 weeks of gestation, UAPI should be performed even in the absence of signs of twin-to-twin transfusion syndrome or growth discordance, uncomplicated monochorionic twins, and plotted on standard charts. This may be best performed in a multiple pregnancy clinic. What are the optimal methods of screening for specific complications of monochorionic twin pregnancies? Screening for twin-to-twin transfusion syndrome. Screening for twin-to-twin transfusion syndrome by first trimester, nuchal translucency measurements should not be offered. Women with monochorionic twin pregnancies should be asked to report sudden increases in abdominal size or breathlessness to healthcare professionals in their secondary or tertiary centers, as this may be a manifestation of twin-to-twin transfusion syndrome. Screening for twin-to-twin transfusion syndrome should be by ultrasound examination from 16 to 0 weeks onwards at 2 weekly intervals, noting and recording fetal biometry and liquor volumes, deepest vertical packet. Fetal bladders should also be visualized. Unfortunately, common symptoms of twin pregnancy overlap with those associated with pathological conditions such as twin-to-twin transfusion syndrome. Pregnant women with monochorionic twins should have a low threshold for presenting to healthcare professionals with concerns. This should be discussed by healthcare professionals at their first booking visit. The ultrasound diagnosis of twin-to-twin transfusion syndrome is based on the following criteria: significant amniotic fluid discordance. This is the key to the diagnosis. There must be oligohydramnios with DVP less than 2 cm in one sac, the donor, and polyhydramnios in the other sac, DVP more than 8 cm before 20 weeks of gestation and more than 10 cm after 20 weeks of gestation, the recipient. Discordant bladder appearances with no urine in the donor fetal bladder in severe twin-to-twin transfusion syndrome presenting before 26 weeks of gestation. Hemodynamic and cardiac compromise both in the recipient and/or donor twins. If there is a Liker volume discordance in monochorionic twins that does not reach the threshold for the diagnosis of twin-to-twin transfusion syndrome, management should be individualized with a high degree of vigilance. Screening for twin anemia polycythemia sequence. Twin anemia polycythemia sequence, or TAPS, should be screened for following fetoscopic laser ablation for twin-to-twin transfusion syndrome and in other complicated monochorionic pregnancies requiring referral to a fetal medicine center, such as those complicated by selective growth restriction by serial MCA-PSV. Twin anemia polycythemia sequence is a form of twin-to-twin transfusion syndrome characterized by a significant discordance in hemoglobin level between twins without significant amniotic fluid discordance. This can be diagnosed by the presence of increased MCA-PSV in the donor, suggestive of fetal anemia greater than 1.5 multiples of the normal median, and a decreased MCA-PSV in the recipient twin, suggestive of polycythemia less than 1.0 multiples of the normal median, with the absence of significant oligohydramnios and/or polyhydramnios sequence. TAPS may occur spontaneously in up to 2% of monochorionic twins and in up to 13% following fetoscopic laser for twin-to-twin transfusion syndrome. The placentas in monochorionic pregnancies complicated by TAPS are characterized by the presence of only a few minuscule artery-vein vascular anastomosis. These small anastomoses allow a slow transfusion of blood from the donor to the recipient, leading progressively to a significant discordance in hemoglobin levels. The absence of severe amniotic fluid discordances in TAPS may be related to the very slow intertwin blood transfusion, allowing more time for hemodynamic compensatory mechanisms to take place. Because twin anemia polycythemia sequence mainly occurs in complicated cases, and because there is little evidence to guide management, screening of monochorionic twins for TAPS using serial MCA-PSV measurements is not routine and should be confined to complicated monochorionic twin pregnancy where the risk of TAPS is high, those with twin-to-twin transfusion syndrome or selective growth restriction. Postnatal diagnosis of twin anemia polycythemia sequence is based on the presence of chronic anemia in the donor, including reticulocytosis and polycythemia in the recipient. Postnatal hematological criteria include an intertwin hemoglobin difference greater than 80 grams per liter and a reticulocyte count ratio greater than 1.7. Screening for SGR or selective growth restriction. At each scan from 20 weeks of gestation at 2 weekly intervals onwards, calculate estimated fetal weight discordance using 2 or more biometric parameters. Calculate percentage estimated fetal weight discordance using the following formula: larger twin EFW minus smaller twin EFW divided by larger twin EFW multiplied by 100. Liker volumes as deepest vertical packet should be measured and recorded to differentiate from twin-to-twin transfusion syndrome. An EFW discordance of greater than 20% is associated with an increase in perinatal risk. Such pregnancies should be referred for assessment and management in fetal medicine units with recognized relevant expertise. Umbilical artery Doppler evaluation in monochorionic twins with selective growth restriction allows definition of prognosis and potential morbidity. In particular, those with absent or reversed end diastolic velocities and cyclical umbilical artery Doppler waveforms, intermittent AREDV or IA-REDV, are at increased risk of perinatal mortality and morbidity. Unequal placental sharing and marginal or filamentous cord insertions are common in monochorionic twins and can result in discordant fetal growth where one fetus is usually normal size and the other small for gestational age, defined as estimated fetal weight less than the 10th centile. However, even if both fetuses have an estimated fetal weight greater than the 10th centile, there may be significant size discordance. This is termed selective growth restriction. Selective growth restriction, or SGR, is encountered in approximately 10 to 15% of all monochorionic multiple pregnancies. The prospective diagnosis initially may be difficult as there may be diagnostic overlap between mild twin-to-twin transfusion syndrome and selective growth restriction. Amniotic liquor volumes, DVP, in twin-to-twin transfusion syndrome may differ between the fetuses because of polyhydramnios in one of the amniotic sacs and oligohydramnios in the other amniotic sac, but SGR may also be present. However, in isolated SGR, this will differ as there is commonly oligohydramnios in one of the amniotic sacs and normal liquor in the other amniotic sac. Poor in utero growth of both twins may reflect multifactorial causes such as maternal factors resulting in global uteroplacental dysfunction, whereas discordant twin growth may be attributed to differences in genetic potential between co-twins, placental dysfunction confined to one placenta only, or one placental territory within a shared placenta. In addition, twin-to-twin transfusion syndrome represents a distinct entity of which discordant growth is a common feature. Discordant growth is recognized as an independent risk factor for adverse perinatal outcome in monochorionic twins and is associated with a substantial increase in perinatal mortality and morbidity for both twins. Calculated difference in estimated fetal weight is a sensitive method of defining SGR and appears to be linked with adverse outcome when this is significantly different. Umbilical artery waveforms in monochorionic twins with selective growth restriction may reflect adverse prognosis for the pregnancy. For this reason, the guideline recommends that umbilical artery Doppler pulsatility index measurements are taken from 20 weeks of gestation and plotted on gestational nomogram charts, with umbilical artery Doppler velocities noted to have positive or AREDV from 16 weeks. Doppler waveforms may demonstrate positive diastolic velocities type 1, AREDV type 2, or cyclical diastolic waveforms type 3 with an attendant worsening of prognosis for perinatal mortality and morbidity. IA-REDV on umbilical artery Doppler velocity assessment are more common in MCDA SGR 45% than uncomplicated pregnancies 5% or those complicated by severe twin-to-twin transfusion syndrome 2%. This condition appears to result from large artery-to-artery anastomosis. Selective growth restriction type 1 is associated with a relatively good outcome more than 90% of perinatal survival. Type 2 selective growth restriction is associated with a high risk, up to 29%, of intrauterine demise of the growth-restricted twin and/or preterm delivery. Type 3 selective growth restriction is associated with a 10 to 20% risk of unexpected fetal demise of the smaller twin, even if stable ultrasound features and/or normal computerized cardiotocography hours or days before, and a 10 to 20% risk of neurological injury in the larger twin.